Emergency medical technician or ambulance technician are terms used in some countries to denote a healthcare provider of emergency medical services. EMTs are clinicians, trained to respond quickly to emergency situations regarding medical issues, traumatic injuries and accident scenes. EMTs are most commonly found working in ambulances, but should not be confused with ambulance drivers or ambulance staff who in the past were not trained in emergency care or driving. EMTs are often employed by ambulance services, governments, and hospitals, but are also sometimes employed by fire departments, in police departments, and there are many firefighter EMTs and police officer EMTs. EMTs operate under a limited scope of practice. EMTs are typically supervised by a medical director, who is a physician. Some EMTs are paid employees, while others are volunteers. Canada, of considerable relevance to understanding the nature of Canadian paramedic practice, the reader must appreciate the considerable degree of interprovincial variation. Although a national consensus identifies certain knowledge, skills, and abilities as being most synonymous with a given level of paramedic practice, each province retains ultimate authority in legislating the actual administration and delivery of emergency medical services within its own borders. For this reason, any discussion of paramedic practice in Canada is necessarily broad and general. Specific regulatory frameworks and questions related to paramedic practice can only definitively be answered by consulting relevant provincial legislation, although provincial paramedic associations may often offer a simpler overview of this topic when it is restricted to a province-by-province basis. In Canada, the levels of paramedic practice as defined by the National Occupational Competency Profile are, emergency medical responder, primary care paramedic, advanced care paramedic, and critical care paramedic. Regulatory frameworks vary from province to province, and include direct government regulation to professional self-regulating bodies, such as the Alberta College of Paramedics. Though the title of paramedic is a generic description of a category of practitioners, provincial variability in regulatory methods accounts for ongoing differences in actual titles that are ascribed to different levels of practitioners. For example, the province of Alberta has legally adopted the title Emergency Medical Technician, or EMT, for the primary care paramedic, and paramedic only for those qualified as advanced care paramedics, advanced life support providers. Only someone registered in Alberta can call themselves an EMT or paramedic in Alberta. The title is legally protected. Almost all other provinces are gradually moving to adopting the new titles, or have at least recognized the NOCP document as a benchmarking document to permit interprovincial labor mobility of practitioners, regardless of how titles are specifically regulated within their own provincial systems. In this manner, the confusing myriad of titles and occupational descriptions can at least be discussed using a common language for comparison's sake. Emergency medical responder. Most providers that work in ambulances will be identified as paramedics by the public. However, in many cases, the most prevalent level of emergency pre-hospital care is that which is provided by the emergency medical responder. This is a level of practice recognized under the National Occupational Competency Profile, although unlike the next three successive levels of practice, the EMR is not specifically considered a paramedic, per se. The high number of EMRs across Canada cannot be ignored as contributing a critical role in the chain of survival, although it is a level of practice that is least comprehensive, and is also generally not consistent with any medical acts beyond advanced first aid and oxygen therapy, with the exception of automated external defibrillation. Primary care paramedics. Primary care paramedics are the entry level of paramedic practice in Canadian provinces. The scope of practice includes performing semi-automated external defibrillation, interpretation of full-lead ECGs, administration of symptom relief medications for a variety of emergency medical conditions, performing trauma immobilization, and other fundamental basic medical care. Primary care paramedics may also receive additional training in order to perform certain skills that are normally in the scope of practice of advanced care paramedics. This is regulated both provincially and locally, and ordinarily entails an aspect of medical oversight by a specific body or group of physicians. This is often referred to as medical control, or a role played by a base hospital. For example, in the province of Ontario, many paramedic services allow primary care paramedics to perform 12-lead ECG interpretation, or initiate intravenous therapy to deliver a few additional medications. Advanced care paramedics. The advanced care paramedic is a level of practitioner that is in high demand by many services across Canada. However, still not all provinces and jurisdictions have ACPs. The ACP typically carries approximately 20 different medications, although the number and type of medications may vary substantially from region to region. ACPs perform advanced airway management including intubation, surgical airways, intravenous therapy, place external jugular four lines, perform needle thoracotomy, perform and interpret 12-lead ECGs, perform synchronized and chemical cardioversion, transcutaneous pacing, perform obstetrical assessments, and provide pharmacological pain relief for various conditions. Several sites in Canada have adopted pre-hospital fibrinolytics and rapid sequence induction, and pre-hospital medical research has permitted a great number of variations in the scope of practice for ACPs. Current programs include providing ACPs with discretionary direct 24-hour access to PCI labs, bypassing the emergency department, and representing a fundamental change in both the way that patients with ST segment elevation myocardial infarctions are treated, but also profoundly affecting survival rates. 12. As well as bypassing a closer hospitals to get an identified stroke patient to a stroke center. Critical care paramedic. Critical care paramedics are paramedics who generally do not respond to 9-1-1 emergency calls, with the exception of helicopter scene calls. Instead, they focus on transferring patients from the hospital they are currently in to other hospitals that can provide a higher level of care. CCPs often work in collaboration with registered nurses and respiratory therapists during hospital transfers. This ensures continuity of care. However, when acuity is manageable by a CCP or a registered nurse or respiratory therapist is not available, CCPs will work alone. Providing this care to the patient allows the sending hospital to avoid losing highly trained staff on hospital transfers. CCPs are able to provide all of the care that PCPs and ACPs provide. That being said, CCPs significantly lack practical experience with advanced skills such as initiation, peripheral access to cardiovascular system for fluid and drug administration, advanced airway, and many other techniques. Where an PCP and ACP may run 40 to 50 medical codes per year, a CCP may run 1 to 2 in an entire career. 4 IO starts are nearly non-existent in the field, and for this reason CCPs are required to attend nearly double the amount of time in classroom situations or in hospital to keep current. In addition to this, they are trained for other skills such as medication infusion pumps, mechanical ventilation and arterial line monitoring. 13. CCPs often work in fixed and rotary wing aircraft when the weather permits and staff are available, but systems such as the Toronto EMS Critical Care Transport Program work in land ambulances. ORNGE Transport operates both land and aircraft in Ontario. In British Columbia, CCPs work primarily in aircraft with a dedicated critical care transport crew in trail for long-distance transfers and a regular CCP street crew stationed in South Vancouver that often also performs medevacs, when necessary. Training. Paramedic training in Canada varies regionally. For example, the training may be 6 months or 2 to 4 years in length. The nature of training and how it is regulated, like actual paramedic practice, varies from province to province. Ireland. Emergency medical technician is a legally defined title in the Republic of Ireland based on the standards set down by the Pre-Hospital Emergency Care Council. Emergency medical technician is the entry-level standard of practitioner for employment within the ambulance service. Currently, EMTs are authorized to work on non-emergency ambulances only, as the standard for emergency calls is a minimum of a 2 paramedic crew. EMTs are a vital part of the voluntary and auxiliary services where a practitioner must be on board any ambulance in the process of transporting a patient to hospital. United Kingdom. Emergency medical technician is a term that has existed for many years in the United Kingdom. Some National Health Service ambulance services are running and conversion courses for staff who were trained by the Institute of Healthcare Development as ambulance technicians and assistant ambulance practitioners. Ambulance trusts such as the London Ambulance Service and the North West Ambulance Service are in the process of converting existing ambulance technicians into emergency medical technician grades 1, 2, 3 or 4, based on their level of experience. In many cases providing a similar level of care to that of a paramedic. Emergency medical technicians are still widely deployed in private ambulance companies with IHCD NHS-trained emergency technicians being particularly sought after. There are also many newer and training courses available. IHCD ambulance technicians and assistant ambulance practitioners still exist within other UK ambulance services with emergency care assistants employed in some areas as support. However, this grade of staff is now being phased out and replaced with a much lower qualified emergency care assistants. United States. History. EMT program in the United States began as part of the Alexandria Plan in the early 70s. In addition to a growing issue with injuries associated with car accidents. Emergency medicine as a medical specialty is relatively young. Prior to the 1960s and 70s, hospital emergency departments were generally staffed by physicians on staff at the hospital on a rotating basis, among them general surgeons, internists, psychiatrists, and dermatologists. Physicians in training, foreign medical graduates and sometimes nurses also staffed the emergency department. EM was born as a specialty in order to fill the time commitment required by physicians on staff to work in the increasingly chaotic emergency departments of the time. During this period, groups of physicians began to emerge who had left their respective practices in order to devote their work completely to the ED. The first of such groups was headed by Dr. James DeWitt Mills who, along with 4 associate physicians, Dr. Chalmers A. Lowridge, Dr. William Weaver, Dr. John McDade, and Dr. Stephen Pner at Alexandria Hospital, VA established July 24 year-round emergency care which became known as the Alexandria Plan. It was not until the establishment of American College of Emergency Physicians, the recognition of emergency medicine training programs by the AMA and the AOA, and in 1979 a historical vote by the American Board of Medical Specialties that EM became a recognized medical specialty. The nation's first EMTs were from the Alexandria Plan working as emergency care technicians serving in the Alexandria Hospital emergency room. The training for these technicians was modeled after the established physician assistant training program and later restructured to meet the basic needs for emergency pre-hospital care. On June 24, 2011, the Alexandria Hospital celebrated the 50th anniversary of the Alexandria Plan. In attendance were 3 of the nation's first EMTs, David Stover, Larry Jackson, and Kenneth Weaver. Certification. In the United States, EMTs are certified according to their level of training. Individual states set their own standards of certification and all EMT training must meet the minimum requirements as set by the National Highway Traffic Safety Administration's standards for curriculum. The National Registry of Emergency Medical Technicians is a private organization which offers certification exams based on NHTSA education guidelines. Currently, NREMT exams are used by 46 states as the sole basis for certification at one or more EMT certification levels. An NREMT exam consists of skills and patient assessments as well as a written portion. The Veteran Emergency Medical Technician Support Act of 2013, H.R. 235 in the 113th United States Congress, would amend the Public Health Service Act to direct the Secretary of Health and Human Services to establish a demonstration program for states with a shortage of emergency medical technicians to streamline state requirements and procedures to assist veterans who completed military EMT training while serving in the armed forces to meet state EMT certification and licensure requirements. The bill passed in the United States House of Representatives, but has not yet been voted on in the United States Senate. Levels. The NHTSA recognizes 4 levels of EMTs, EMT B, EMT I/85 EMT I/99 EMT P, Some states also recognize the advanced practice paramedic or critical care paramedic level as a state-specific licensure above that of the paramedic. These critical care paramedics generally perform high-acuity transports that require skills outside the scope of a standard paramedic. In addition, EMTs can seek out specialty certifications such as Wilderness EMT, Wilderness Paramedic, Tactical EMT, and Flight Paramedic. Transition to new levels. In 2009, the NREMT posted information about a transition to a new system of levels for emergency care providers developed by the NHTSA with the National EMS Scope of Practice project. By 2014, these new levels will replace the fragmented system found around the United States. The new classification will include emergency medical responder, emergency medical technician, advanced emergency medical technician, and paramedic. Education requirements in transitioning to the new levels are substantially similar. EMT-B. EMT Basic is the entry level of EMS. The procedures and skills allowed at this level are generally non-invasive such as bleeding control, positive pressure ventilation with a bag valve mask, oropharyngeal airway, nasopharyngeal airway, supplemental oxygen administration, and splinting. Training requirements and treatment protocols vary from area to area. Intermediate levels of EMT. EMT intermediates are the levels of training between basic and paramedic. There are two intermediate levels that are tested for by the NREMT, the EMTI/85 and the EMTI/99, with the 1999 level being the more advanced of the two. The standard curriculum for EMTI from 1998 is defined by the NHTSA, but each state may not have implemented or approved this program. Many states have stopped issuing new intermediate licensure, instead focusing on maintaining the current lists of intermediate they have, and encouraging the basic to paramedic program philosophy. Outside of the NHTSA framework, some states have instituted their own intermediate and levels using a variety of names. EMTI/85 EMTI/85 is a level of training that will typically allow several more invasive procedures than are allowed at the basic level, including for therapy, the use of multi-lumen airway devices, and provides for enhanced assessment skills. EMTI/99, the EMTI/99 represents a higher level than the EMTI/85 with an expanded scope of practice, such as cardiac monitoring and the administration of additional pharmaceutical interventions, as well as additional training time. EMT-P, EMT paramedics, who are commonly referred to as simply paramedics, represents the highest level of EMT, and in general, the highest level of pre-hospital medical provider, though some areas utilize physicians as providers on air ambulances or as a ground provider. Paramedics perform a variety of medical procedures such as fluid resuscitation, pharmaceutical administration, obtaining for access, cardiac monitoring, and other advanced procedures and assessments. Staffing levels. An ambulance with only EMT-BS is considered a basic life support unit, an ambulance utilizing EMT is dubbed an intermediate life support unit, and an ambulance with paramedics is dubbed an advanced life support unit. Some states allow ambulance crews to contain a mix of crews levels to staff ambulances and operate at the level of the highest trained provider. There is nothing stopping supplemental crew members to be of a certain certification, though. Education and training. EMT training programs for certification vary greatly from course to course, provided that each course at least meets local and national requirements. In the United States, EMT-BS receive at least 110 hours of classroom training, often reaching or exceeding 120 hours. EMTs generally have 400 hours of training, and EMT-PS are trained for 1,000 hours or more. In addition, a minimum number of continuing education hours are required to maintain certification. For example, to maintain NREMT certification, EMT-BS must obtain at least 48 hours of additional education and either complete a 24-hour refresher course or complete an additional 24 hours of CEs that would cover, on an hour-by-hour basis, the same topics as the refresher course would. Recertification for other levels follows a similar pattern. EMT training programs vary greatly in calendar length. For example, Fast-track programs are available for EMTs that are completed in 2 weeks by holding class for 8 to 12 hours a day for at least 2 weeks. Other training programs are months long, or up to 2 years for paramedics in an associate's degree program. In addition to each level's didactic education, clinical rotations may also be required. Similar in a sense to medical school clinical rotations, EMT students are required to spend a required amount of time in an ambulance and on a variety of hospital services in order to complete a course and become eligible for the certification exam. The number of clinical hours for both time in an ambulance and time in the hour vary depending on local requirements, the level the student is obtaining, and the amount of time it takes the student to show competency. EMT training programs take place at numerous locations, such as universities, community colleges, technical schools, hospitals or EMS academies. Every state in the United States has an EMS-led agency or state office of emergency medical services that regulates and accredits EMT training programs. Most of these offices have websites to provide information to the public and individuals who are interested in becoming an EMT. Medical direction: in the United States, an EMT's actions in the field are governed by state regulations, local regulations, and by the policies of their EMS organization. The development of these policies are guided by a physician medical director, often with the advice of a medical advisory committee. In California, for example, each county's local emergency medical service agency issues a list of standard operating procedures or protocols, under the supervision of the California Emergency Medical Services Authority. These procedures often vary from county to county based on local needs, levels of training and clinical experiences. New York State has similar procedures, whereas a regional medical advisory council determines protocols for one or more counties in a geographical section of the state. Treatments and procedures administered by paramedics fall under one of two categories: offline medical orders or online medical orders. Online medical orders refers to procedures that must be explicitly approved by a base hospital physician or registered nurse through voice communication and are generally rare or high-risk procedures. In addition, when multiple levels can perform the same procedure, a procedure can be both an online and a standing order depending on the level of the provider. Since no set of protocols can cover every patient's situation, many systems work with protocols as guidelines and not cookbook treatment plans. Finally, systems also have policies in place to handle medical direction when communication failures happen or in disaster situations. The NHTSA curriculum is the foundation standard of care for EMS providers in the U.S. Employment: EMTs are employed in varied settings ranging from industrial and entertainment positions to hospital and healthcare settings, and the pre-hospital environment. The pre-hospital environment is loosely divided into non-emergency and emergency services, but many ambulance services operate both non-emergency and emergency care. In many places across the United States, it is not uncommon for the primary employer of EMTs to be the fire department, with the fire department providing the primary emergency medical system response. In other locations, such as Boston, Massachusetts, emergency medical services are provided by a separate, or a third-party government agency. In still other locations, emergency medical services are provided by volunteer agencies. College and university campuses may provide emergency medical responses on their own campus using students. In some states of the U.S., many EMS agencies are run by independent non-profit volunteer first aid squads that are their own corporations set up as separate entities from fire departments. In this environment, volunteers are hired to fill certain blocks of time to cover emergency calls. These volunteers have the same state certification as their paid counterparts. See also: combat medic, emergency medical services in the United States, emergency medical services in the United Kingdom, paramedics in Canada, references and notes. External links: National Highway Traffic Safety Agency, Office of Emergency Medical Services, United States National Registry of Emergency Medical Technicians, Basics for the Training of Emergency Medical Technicians.